Okay, how many new people do we have in here? New people. How many people haven't seen my annual infection control in service? Oh boy. Okay, this is this year's infection prevention program, and it also will include bloodborne pathogens. What? Hello? Can you guys hear me?
I heard you.
The aging population of long-term care facilities are at a greater risk of infection because of deterioration of their immune response. We will talk about that further on. The acuity of care in long-term care has increased over the last 20 years. And I can honestly say it has, because I see people here now in the nursing home that I used to see in the hospital 20, 30 years ago. Lapses in infection prevention activities not only increase the risk of intra-facility transmissions, but also are often associated with citations by the Centers for Medicaid and Medicare Services. CMS has adopted the culture change concept that encourages facilities to develop care and quality of life that is person-centered. Well, how does this influence infection control? This also requires more input on care decisions from families and residents. This is the resident's home, and sometimes compromises in education are required to make it a safe place, but also more home-like for them. One of the things that we are doing is on admission and at care conferences, we are including the antibiotic stewardship program that talks to families and residents about why it is that we don't want to give so many antibiotics with all the resistance that it's causing. Because the first thing family members or residents want to do is put somebody on an antibiotic, that will solve everything. Okay, the resident population. What do we have here? And this goes into what most of you probably don't know about, the facility assessment that had to be done on the different types of people that we take care of here, and we have to show that we have all the equipment and we have the knowledge to take care of them. So, first one is we see a lot of dementia. Someone could be perfectly healthy, but because of dementia, they may have poor health hygiene. So someone could even spread C. diff, which is normally caused from it being on an antibiotic. I've seen C. diff occur in someone that has poor hygiene. So it does happen. Of course, the decrease in the immune response, decreased skin integrity and wounds. We see a lot of skin tears now in our residents. Residents with nutrition, chewing, and swallowing. Sometimes this nutritional part is not really thought of as the importance, and this needs to be reminded to residents and family members also, that how healthy someone is depends a lot on what kind of nutrition they're taking in. Issues with incontinence, increased fragility, decreased bowel and bladder function, decreased mobility. The infection prevention plan includes hand hygiene and glove use, isolation, and PPE. There is a process for how you are supposed to apply and take off the PPE. With the precaution room cart, there is those procedures written on there. So they need to be looked at before you go into a room and come out. You need to know what process or what procedure you're supposed to follow to put them on and take them off, so you don't recontaminate yourself. Surveillance priorities, definitions, methods, analysis, and reporting. That's pretty much the part that I do. That's why I go around asking a bunch of questions. The tuberculosis control, seasonal influenza immunization program, that'll be coming up starting in September. Pneumococcal immunization program required by the CMS to be up to date unless refused. So now the nurses, when the RCMs do the MDS that they have to transmit to the state, they have to put down whether or not their pneumococcal and flu vaccines are up to date. And if they're not, they have to mark that. So we are now required that they have to be up to date or we can get fined for 2 pneumococcals, and 1 Prevnar 13 vaccine, and of course their flu vaccine. If a resident refuses, they really need to sign that they refused. Public reporting flu outbreak and flu epidemic procedures. I like to forget about those times. Lab utilization and reporting. Antibiotic use and stewardship program. Cleaning, disinfection of the environment and care equipment. Okay. Approve facility cleaning and disinfecting products. Prevention of MDRO transmission. What is our process that we use now for MDROs, multi-drug resistant organisms? How do we know when they have them? The people that come in, the people that are admitted. You could be a carrier and we still have to have down that you've had a history of multi-drug resistant organisms. We have the MDRO sheet, and that's the sheet that the nurses fill out when people are admitted, and that gets transmitted. I get a copy of it so I know who has a history or who doesn't have a history, or I may adjust it in case, because I can get onto the hospital computer and the charge nurses can't, so sometimes I will find out that they do have a history and I'll go in and change it. But that form is supposed to go to, with the resident wherever they go. And this is a actual policy that we can get tagged for if we are not doing. This was a decision because of all the MDROs that have gone on, that all hospitals, nursing homes, I'm not sure who else, has to give that MDRO form to whoever they're transporting them to. Okay. And it needs to be up to date. Environmental monitoring and surveillance, storage of clean and sterile supplies, establishing and updating policies and procedures, educating staff, and then part of QAPI, which is a Quality Assurance Performance Improvement team. Hand hygiene and gloves are standard precautions. Healthcare associated infections place a serious disease burden and has significant economic impact on patients and the healthcare system throughout the world. Treating infections is becoming more and more expensive. Yet good hand hygiene, the simple task of cleaning your hands at the right time and in the right way, can save lives. I wish that you could see the germs on your hands so that you will know what you're transmitting to residents when you don't use the proper procedure. Wash your hands before and after contact with the resident or their environment, after contact with blood, body fluids, secretions, excretions, contaminated items, immediately after removing gloves, between resident contact, before and after food preparation and service. Do you need to wash your hands or use hand hygiene when you're entering a room? It doesn't matter what you did in the old room or where you came from. You've got to wash your hands or use hand gel when you're going into a room. And thank you very much. During our mock surveys, we got nothing for hand hygiene. So thank you very much for that. Let's see, alcohol gel is another form of hand hygiene. I actually changed the hand washing policy to hand hygiene policy and included the gel in that. When applying gloves or removing them, do not recontaminate. There's a certain way you have to take them off so that you don't recontaminate your hands. And charge nurses, you are also, and anybody as a staff member is responsible. If they see something being done wrong, they need to bring it up to that person or come and tell me because they're endangering the residents. Transmission-based precautions implemented when resident is known or suspected to be infected by route of transmission with an infectious agent. If we have somebody that we have suspicions that they have C. difficile infection, do we put them in precautions? We wait for the result? Because they may not have it. Do we wait for the result? No, you need to put them in right away, and that includes anybody suspect of having the flu. If you suspect that these infections may occur, then you need to put them in precautions at that time, not waiting for the answer, because that could be, several days of exposure. They should be maintained as long as the resident has clinical signs of infection. Contact infectious agent traveled by contact, we use an orange dot. So if you see an orange dot on our nameplate, you know that person's in contact precautions. How do you find out more? How do you know what kind of precautions you need to have for contact? You just automatically know? There is a paper put in the folder of the person's bathroom folder when they go on precautions that further explains what we're doing. It tells you the resident whether they can come out of the room, how they can come out of the room. Yes, people do come out of the room that have infections, but the area has to be contained. The person has to have clean clothes, and the person also has to have their hands washed. So you skip that part, and you might as well just forget the whole thing. Droplet infectious agent travels in the air but drops due to heaviness of the particle. That's a green dot. What do we see as a droplet infection? Everybody enjoys that time. Huh? The flu. That's what we use for droplet. Or we use droplet precautions when we have the flu. And during an outbreak, of course, we sometimes will use precautions on everybody because we don't know who's getting it, who's ending with it, or what. So we just use precautions altogether, trying to get it out of the building. Airborne particles are light and travel through the air and into the air ducts. These residents will require a negative pressure room, and they're sent to the hospital. If you have somebody who's suspect of having TB, which falls under this category, what would you do? We have a lively group here.
Call an ambulance.
Probably somebody would come and tell me, Joanne, will you please take care of this? But the first thing you'd want to do is put a mask on them if they're in a semi-private room. Try to remove the other resident, shut the door. And in this process, what happens is I would call the emergency room and let them know that we're going to be sending somebody that we are suspicious of having tuberculosis. And those are people that are actually showing signs of tuberculosis. Anybody know what they are? That's, when I worked in Florida, when we get people with suspected TB, the number one thing we always saw was they'd cough up blood. So we saw that. Weight loss, night sweats. Requirements for precaution room. How do you know what you need? Where do you find this information? You don't know where to go to find this information, no one.
You.
There is a book on both sides now. No, that's a disaster manual. This is just for precaution rooms.
This sounds like a disaster.
There is a binder on both Dove's Nest and in rehab that actually have it laid out what is the process, what equipment you need to start a precautions room, and then down below that it has how to end a precaution room. There's certain steps that have to be taken. Yes, it is usually the nurse that looks at this book. And you really need to look at it because people tend to forget parts of it. We are now able to put a sign on the door that says check with the nurse's station. We weren't allowed to do that before, but we are now. So there should be a sign on the door. There should be a dot on the nameplate. We should have a bleach container with wipes inside of a locked container. Dedicated equipment. So what is the important part of when they come out of precautions?
Everything away that has germs on it, like toothbrushes,
that belong to us. We can't throw their personal items out. Anything, you know, that you think, okay, if somebody had the flu, what would be the one thing you'd want to throw out? Thank you. Yes. So you have to stop and think. If somebody goes, and this is not even just a precaution room. If somebody goes to the hospital and they were using an oxygen concentrator, they've been gone for 5 days. You come back, you hook them right back up to it. You're supposed to clean it. Okay. Possibly a bedside commode, that's up to the discretion of the nurse. We won't have to deal with that once we move into the new building and everybody has private rooms. So, the placement of residents. How do we look to determine if we have somebody in-house that all of a sudden has a drug-resistant bacteria where they need to be in precautions, or someone that's admitted? This is the steps that we look at from best to worst scenario. The best is if they're in a private room, okay? We don't even have that capability now, but we will. Residents that share the same infection. Can you put 2 people in the same room that have MRSA? Can you put 2 people in the same room that have 2 multi-drug resistant organisms? If it's the same infection. For example, VRE, vancomycin-resistant enterococcus, and MRSA, methicillin-resistant Staph aureus, you do the same things for both of them, but they're both contact, but you can't have them in the same room because they can cross-contaminate each other. So, but if you have 2 people with MRSA, you can keep them in the same room. If the resident, the next step would be to put a resident in with good health and good immune system. So that would be probably someone most likely that is long-term care. Respiratory infections, try and keep division curtains separating the beds 3 to 6 feet away. That is for droplet precautions. MRSA, avoid residents that have devices or opening the skins passed by contact. So with MRSA, you really try to avoid having 2 devices in the same room. You don't want to have IVs in the same room with Foley catheters, Foleys with Foleys, 2 IVs. You don't want to have somebody with a wound that put in the same room with somebody who has MRSA. You don't really, if somebody is found to have C. diff, is most likely caused by being on antibiotics, so you want to make sure that you're not putting a person with C. diff in a room with somebody who's on antibiotics. So there's different things that we have to look at. C. diff is also GI surgeries and colostomies. Anything with the bowel manipulation is a risk. How to take them out, it's decided by the nurse. Sometimes I'm involved, sometimes I'm not. Notify housekeeping. Why do we want to notify housekeeping? Because they have to clean the room. Resident comes out of the room clean. Shower is best. So it's an agreement between the nursing staff and housekeeping to get this room taken care of. Housekeeping does the terminal cleaning. We now have the bleach wipes in case they're supposed to be removed by the housekeeping. The dedicated equipment is supposed to be thrown out by the housekeeping. Information sheet and door sign is removed by housekeeping. Dot removed from the door by housekeeping. Resident's gate bell should go into the laundry and obtain a new one. That would be nursing. And infection control form gets completed. That would also be nurses. So why do we have housekeeping doing all this? Because we found when we were taking people off precautions, somebody inevitably would go take the dot off and the room hadn't been cleaned. So housekeeping goes in first. They're the ones that remove the dot. Then you know that the room has been cleaned. Maintain transmission-based precautions longer than necessary may adversely affect the psychological well-being of the resident. They don't care about this in the hospital. This is residents' home, and the longer we keep them isolated and under precautions, the more we're socially isolating them. So we don't just keep it, we shouldn't keep people in precautions any longer than we have to. Okay? You don't leave them on for a week just to make sure. Because we don't do post lab work anymore anyway, unless the doctor orders it. Activities, dining, and rehab. Residents may come out of the room if the infection can be contained. Resident clothes are clean. A resident has cleaned their hands. Respiratory hygiene, cough etiquette. Instructs symptomatic residents to cover their mouth and nose when sneezing, coughing, or use tissues and dispose in a receptacle. Do not bring residents that are sick and coughing into the dining room. Mostly this involves CNAs. So because people are just used to taking certain people to the dining room, certain time of the day, and that's what happens, you still have to stop and think if somebody is running a fever, if somebody has got drainage coming out of their eye, if they're coughing, and it sounds very moist. These people should not be coming in there, okay? Very hard for the nurses to keep track of that because they're not the ones that are taking them and taking them out. So you're really CNAs, you need to know what's going on with the resident and determine, you can go ask the nurse if they think that they should stay in their room. Maintain spatial separation of 3 feet between resident beds. Update method is to cough into your elbow. Everybody know that? Okay. Please give residents, if they're starting to get sick, please give them the equipment to decrease the cross-contamination, such as tissues and a garbage bag. How many people walked in the room and somebody's got a cold or something and there's tissues all over the floor? Surveillance data collection. Surveillance is just a matter of fact of going around and looking. And everybody knows I do that, and I pretty much do it on a routine basis. Because if people don't look, people don't do. So, I'd love to take a CNA with me when I do it, so they can see what I'm looking at. The difficult part of it is, though, that most of the time, the best time to do this is when residents are out of the room, because they question me as to what I'm doing and they don't quite understand what I'm doing, so I try to get into the rooms when they're out. Is a systematic collection, analysis, interpretation, and dissemination of data to identify infections and infection risks. We are becoming more like hospitals where we just don't document anymore. We have to analyze the situations. Potential areas of cross-contamination, collection of useful, relevant, and timely information in order to identify trends and develop interventions that help to prevent and control infections. Systems to monitor actual healthcare practices, surveillance checks, resident rooms, med and treatment cart. Tuberculosis. We are at low risk in this area, and our policy depends on the risk level. I've been here 10 years, and the risk level has always been low. And under the low risk level, our policy states that you do a 2-step TB test and you don't have to do anything further. If we were going to moderate risk, which the health department is the one that picks the level every year, then we would have to do an annual TB test. So if we would become high risk, I'd have to write a policy because I don't have one for high risk. Residents, volunteers, students, and new employees are assessed for signs and symptoms of TB and a 2-step TB test. The back of that TB sheet, the orange sheet where you're getting the TB test, that has to be filled out and signed by a nurse. Communicable disease and needs to initiate it when staff are hired or when a resident is admitted. I'm sorry, what? Oh, well, I probably didn't use spell check. So, what I mean by that is that we need to know if the residents that are coming are contaminated with some type of infection, and we need to make sure whoever the receiving people are knows what's going on with that residence. Okay, a TB test. Do we have to do it? I've asked on several occasions, not the majority of the time, but several occasions, I've asked why a TB test was not done. And the nurse gives me the answer, they refused it. You cannot refuse a TB test because it's a communicable disease, and it's the policy of our facility. So if that's the case and they refuse it, what I would do is go back and look, or have someone that can get into Epic, the hospital computer, and look to see when they last had a chest x-ray done. That chest x-ray then can be printed out, and we can fax it to the doctor with information regarding that person. Okay. It's up to the doctor and the resident's family on whether or not they're going to treat somebody for a positive TB test. What would make the difference? Why would you treat one person differently than another if they both are positive for TB? All of that. So if you have, like one time I had a lady who had a positive TB test. She wasn't symptomatic, but she had been a nurse in World War II. Another time, we looked back in this guy's history, and he had worked in an emergency room. So the older you get, there's always a chance that you could get TB if you've been exposed. Okay. It's not likely, but if your health deteriorates, then there is a possibility that you could get it, and that's why you and your doctors have to decide whether or not you're going to be treated. Okay. When I worked at another facility, I was not the infection control nurse at the time. I was a floor nurse. And we had a resident that was in his 20s, and he had severe cerebral palsy. We did a TB test on him, and it came back positive. We followed through with the doctor. The doctor ordered a chest x-ray. The chest x-ray was negative. We proceeded on with whatever. The mother of this child ended up suing the facility because we did not show follow-up. We did not show that the doctor was made aware of the chest x-ray. We did not show what the doctor's response was to that x-ray. So these are things we can't just stop because, oh, okay, negative, we don't need to do anything. We need to show follow-through with that type of thing because, like I said, you can get in trouble for it. And I don't think the mother had been notified either. Okay. So if you're a known positive, you're going to get a chest x-ray. If you're a new positive, you're going to get a chest x-ray. Under what circumstance may we see a positive that is not necessarily an infected TB person? People who have had a vaccine called BCG. BCG is a vaccine that's given in countries where there's a higher incident of TB. I know all about it because I worked in Florida, and we got people from every island around. And a lot of them had had BCG. And what it is it's a vaccine that helps prevent people from getting TB, but just like any other vaccine, it may not completely cover you, like we've seen with the flu. So it's a helpful thing to keep them from getting tuberculosis, but it's not foolproof. So therefore, those people do need a chest x-ray, because if it's positive, we know it's going to be positive, you still have to proceed to check them because you don't know if it's positive from the BCG or if it's actually tuberculosis. So there's different scenarios that we have to look at. Influenza. It's caused by respiratory virus. What kind of precautions do we use? Droplet. We just went over that. Okay, that's the green dot. Adults can be infectious for about 1 day before symptoms develop, and up to 7 days after becoming sick. The virus can spread to others up to 6 feet away, spread by droplets made when people cough, sneeze, or talk. Symptoms: chills, fever, cough, sore throat, runny nose or stuffy nose, muscle or body aches, headaches, fatigue, vomiting, and diarrhea. Healthcare workers who get vaccinated help reduce the transmission of the flu, decrease staff illness, and lower the risk for related illness and death. Okay. Anybody here worked here when we had the flu in the building? It's not fun. It's horrible. So one of the things that you guys need to do is take notice of what's going on. Anybody can notice whether there's a change in a resident. It seems to occur that we don't want to believe it's the flu. Several people get like a mild cold, and it kind of tends to go for a little bit, and then all of a sudden somebody will tell me that something's going on with this group, and by that time it can be too late. So really you need to let me know if you see anything that's different or going on that you think somebody might be starting, like an outbreak. And how much is an outbreak? How many people do you need for an outbreak? 2. There are new guidelines for the pneumococcal vaccine. I talked to you about that, about them requiring to have them all. A dose of 23-valent pneumococcal polysaccharide vaccine is to be administered to these patients 6 months to 1 year after the PCR-13, which is also a pneumococcal vaccine. The 23 is effective against 23 strains, and the 13 is against 13 strains. They want residents to get the PCR-13 prior to the 23, but most people have already gotten the 23, so we end up giving it after. And if you get that first pneumococcal 23 prior to the age of 65, then you should be getting another one. You want me to repeat it? Okay. If residents are up to date, the MDS has to be signed and not complete. Norovirus. Who was happily here when we've had norovirus?
Not good.
That's worse. Okay. Considered to be the most common cause of gastroenteritis in long-term care facilities and affects both healthcare personnel and residents. Symptoms are acute onset of nausea, vomiting, diarrhea. Individuals are infectious prior to symptoms and up to 10 days after symptoms resolve. The norovirus is also affiliated with what other enclosed group of people? No. Cruise ships. You'll hear about all these cruise ships getting norovirus. Okay, this involves notifying the health department and collecting specimens, both contact and droplet precautions. So you would put an orange dot because it is considered contact, but if somebody is close to the vomit or stool, it forms an aerosol, and it's possible that you can breathe it in if you get close enough to it. So CNAs and housekeepers, I wouldn't go without it. Bloodborne pathogens, hepatitis B vaccine, available to all employees and free to direct care staff. Offer when hired, series of 3 shots over a 6-month period, and then a titer is recommended. Don't be willing to get the vaccine and not want to get a blood test after it's done, because that blood test determines whether or not you truly are covered by that vaccine. If you don't get the titer done, which is a blood draw, then you don't know. And there are such people as non-responders. And those are people, I've only ran across 2, but those are people that you could give them 20 shots of the vaccine and it still wouldn't be effective. So those people basically have to be careful. If you come here as a new employee, you can pick all sorts of different scenarios. If you're not sure if you finish the series, we can give you a booster. If you come and you're not sure if you're still covered, then we can do a titer. So there's variations in what we can do depending on your situation. The hepatitis B vaccine, yes, you're supposed to get one and one a month later and then another one after 6 months from the first one. It does not have to be exact like the TB test does. You can get one, you can get one a month later, then all of a sudden you forget and it's a year, you can get the third one at that time, okay? And I think a lot of kids are going through school now or getting the series. Transmission of hepatitis B, hepatitis C, and HIV to healthcare personnel and residents may occur through improper use or reuse of contaminated blood glucose testing equipment. Gloves must be worn and the monitor appropriately cleaned with the Santi-Wipe pads. If a surveyor sees that we are not doing that, cleaning it with a Santi-Wipe, what possible tag could we get? A J-tag, which can be fined. A J-tag is putting somebody in immediate jeopardy, and it has to be taken care of right away, and you have to write up the whole thing of what you're going to do because you are endangering the resident. A lot of diabetics got hepatitis B before they realized what was going on. OSHA has sharp containers, safety needles, and spill kits basically is what we use for occupational health. And the OSHA is designated for watching over policies and procedures for employees, not for residents. Labs, x-rays, and other diagnostic tests are used to help establish presence of infection, notify MD with information of diagnostic testing and symptoms experienced by the residents. Under antibiotic stewardship, some things have kind of changed. That is I don't think it's just nationwide, I think it's worldwide that we're working on antibiotic stewardship. And we're trying to do it within 5 years. So I think we're like in our 2nd year now. And that's careful consideration for antibiotic use. What we used to do is dip people's urine if they acted a little funny. It looks positive, so we'd plop them on an antibiotic. We don't even dip people's urine anymore. We have criteria now. We use the McGeer criteria, the nurses do, to determine whether or not it even fits within the definition of that type of infection. And we have to use that information to determine how we're going to present it to the doctor. Where you would put down what symptoms the resident's having, but you'd also helpful to put down the parts of the McGeer criteria that they don't meet, such as maybe they're not running a temperature, you just say they're afebrile. Okay. Very important thing is to have urinary symptoms to actually be treated. Overuse of antibiotics can cause multi-drug resistant organisms. Education on limited use of antibiotics for nurses, doctors, residents, family, and all healthcare workers. McGeer criteria, SBAR, and pathways are all ways in helping the nurses determine whether or not what to say to the doctor. Environmental considerations. Monitor environment for possible contamination, transmission of infectious organisms. I always tell the story about how people were freaking out when we had somebody with scabies, and the CNAs had to go in and put this chemical, it's like a pesticide on them, to kill it, and they actually had their head wrapped in saran wrap. We do have hats now available. They were like overly protecting themselves because they could see these scabies, they could see them. But then I've seen other people be nonchalant about going into a room where someone has MRSA. You can't see it. Which is more deadly? MRSA. Although I wouldn't want to have lice either, or scabies. Not sharing supplies in the shower room. Constant when I do my rounds. You cannot have people's personal stuff in the bathrooms. You cannot have stuff that's not labeled in the bathrooms. And that includes the showers. You need to make sure that you're not mixing clean versus dirty. You need to make sure that you're not putting things for one roommate on the side of the other roommate. We talked about not having two residents with the same devices. Hygiene supplies must be marked with the resident's name. This is just another way to prevent cross-contamination. Keep oxygen tubing off the floor, changing oxygen water prior to residents' return from the hospital. Resident rights must be care planned, if not our policy. And what I'm talking about is men's urinals is a big one. Our policy states the urinal will be kept in a plastic bag in the bottom of the nightstand. It's their right to have it where they want it. So if they want to keep it on the bedside table next to their water glass, it needs to be care planned. Okay. We got nabbed from that on our first mock site survey, and what was it? When did we have that other one? June? And this is the same repetitive stuff I see all the time. Environmental cleaning, use appropriate disinfectants. Clean rooms between residents and after precautions are finished and after discharge. When would you not, if somebody was in precautions, and when would we not have to clean the room to take them out? If we have them in precautions while we're testing, and the test comes back negative, we can just remove the stuff. Know your dwell times. Does anybody know what I'm talking about as in dwell times? You'll see these little signs up in the dirty utility room is where they usually are, and they'll have dwell times on there. And those are the chemicals that we use and how long it has to sit on that surface before you wipe off. Okay, a dwell time is how long it has to be on that surface to be effective. If you're not using it properly and giving the proper time, then it's not going to work right. And I looked into that when I found out that surveyors were asking housekeepers about it. Not here. Changing of curtains need to be done for terminal cleaning, cleaning of residents' beds when shower days. How's that going? Are they getting their beds cleaned on their shower days? Does anybody even, huh? Does everybody know that that's supposed to be done? Washing the filters on concentrators. We have concentrators in the room. They have that black spongy filter. You can pull that out and run it under warm sudsy water and dry it off. If you see that, and you probably would see that if somebody was using a higher oxygen level, but normally housekeeping takes care of it. And I do check those when I go in the room. But if you have one that's heavily soiled, don't wait for housekeeping. Just go ahead and run it under water, sudsy water, rinse it off, dry it off, stick it back in. Avoid storing items that need to be cleaned in the shower rooms. Place out back door with sign. Oh, I didn't write that very well. Anyway, there was the big thing about, I've never said that dirty equipment should be stored in a shower room until cleaned. And there is no policy for that. The shower rooms are not considered a place that you put dirty items. Okay, so that way, now what we are doing, if something needs to be cleaned, like a bedside commode or a wheelchair, then you take it out the back door, you put a sign on it, and say it needs to be cleaned, and housekeeping knows that they need to get those and wash them off. I mean, most of the equipment's done when they're being discharged and all, but once in a while something will come up. Normally you would store it in the dirty utility room, but our dirty utility rooms are not big enough. Covering clean linen. Why do I have that in there? All linen has to be covered, okay? You can't leave the cover flopped up. I see it all the time, especially in shower rooms. Somebody flips up something to go get something and then they forget to put it down. we could get tagged for that. Okay, state surveyors, that's not protecting your clean linen. Or, you know, if you don't have it in one of those carts and you're just stacking it, it needs to have something over the top. Any questions?
Yeah. So I didn't know that that's happening during the shower days. So is that like a wipe down with?
They do it. I don't know what they
So
exactly,
we need to have that scheduled with us?
Janie.
Evening shift. What's that? Evening shift showers, they're not here.
I don't know how each RCM does it. I just know it's supposed to be done. And so you need to work that out with housekeeping. Because if you think about it, if somebody is here long-term care, when does it better ever get disinfected? You just collect dust. Yes?
What about on evenings? There's no housekeeping. Are we responsible for?
Talk to your RCM on how they want it done. Okay, does everybody have all the answers to the quiz?